Thank you very much, Dr. Arun, and thank you for making me a part of this course and this wonderful conference. Dr. Kalpana, an outstanding one, truly, with of course, the temperature is also warm, but otherwise also exceedingly warm hospital. Really in nystagmus, these are, I would say, rather exciting times. It's exciting times for actually pediatric ophthalmology and strabismus. Everybody who's here, who's involved with this specialty will tell you that the best about our field is there's so much yet to come. And that's the beauty. In other fields, maybe we've already advanced so much that incremental growth is slow. Here, on an everyday basis, we learn so much about about the same disease and about new diseases and how to manage, and the challenge itself is the most exciting thing that we have. So just a bit about nystagmus. We have various types of nystagmus. It's sometimes difficult when a child comes crying, not very comfortable with wriggly eyes. You just don't know what is happening and what you need to do. You need to be very comfortable and quiet and try and understand, get the parents and the children to be at ease, to explain to them that these are things that require a long-term association and are not things that get treated in magic. So a rhythmic, involuntary to and fro movement of the eye, every word in this is very essential when you're diagnosing nystagmus. They can be pendular or jerky. The direction is according to the fast phase. It may be horizontal, vertical, or rotatory, and all these have often very significant value when you are trying to look at acquired nystagmus. But here I'll be essentially talking about childhood nystagmus. The other thing is conjugacy. Conjugacy essentially means that both eyes have same or similar movement, but disconjugate, that there is different nystagmus in the two eyes. You need to know why that is there. It can be there because there is asymmetric vision, so the better eye vision is able to dampen the eye movement and therefore have better vision, or there may be other major problems like a spasmus nutans. So you have ocular oscillations. You need to know whether it's nystagmus. The nystagmus gets diagnosed if it's rhythmic, involuntary, and to and fro. Others may not be having these characteristics. Nystagmus, then you need to know whether it's physiological or not. So physiological has certain conditions. It's end gaze. It dampens in a bit. It only occurs momentarily. There is no visual defect with it. Pathological nystagmus would be congenital or acquired. Again, you need to identify acquired nystagmus. The patient who comes in is usually very symptomatic, would have oscillopsia, would have some other neurological cause. Else it is congenital. Of course, when in doubt, get an imaging done, and it could be sensory or motor, although it's not generally discussed as sensory motor by CMAS. The most common pathological nystagmus in infancy or early childhood is an infantile nystagmus syndrome, earlier called congenital nystagmus. Fusion maldevelopment, earlier called latent manifest, manifest latent or latent nystagmus as spasmus nutans. So INS is the most common what we see in an ophthalmology clinic. It's uniplanar, binocular, no oscillopsia really, although patient may sometimes tell you that he is occasionally aware of the images moving. It's abolished in sleep. It dampens on convergence, which is something that we use for our management, and there is a distinct ascending slow phase velocity. The latent manifest is again conjugate, it's horizontal, it's jerk. The important thing is fast phase towards the fixing eye. So you alternate the fixing either eye, and the fast phase or the beat moves towards that direction. That is characteristic, and another characteristic is decreasing velocity of the slow phase, and that helps us because latent manifest nystagmus is really never associated with any intracranial pathology. And spasmus nutans you must know, because a small child coming with a head posture, head nodding, asymmetric nystagmus, in the first 6 months you are concerned because they are associated with chiasmal gliomas and you require neuroimaging. If it is not associated with a chiasmal glioma, you may just wait it out. It tends to get better. So imaging required in all cases of acquired nystagmus, periodic alternating nystagmus, seesaw nystagmus, spasmus nutans syndrome, and when you have poor vision and you're not sure why that's happening. We've talked about the head postures and measuring it. For nystagmus, it's important that a patient doesn't walk in with a head posture. You wait some time, let the patient read down the Snellen's chart only when there is a visually demanding task. As the patient is running down the Snellen's, you can see that the head posture is developing. Otherwise, at most times, the patient is straight. So this is the amount of head posture actually the patient has, and if you're planning to operate for it, that's what the level, that's the correction you require. You can do nystagmography, either electro or video nystagmography. And these are the kind of waveforms you get. All these squiggly lines, sometimes it's difficult to understand, but you can see wherever it's flattening out, it's a little better. So here you can see they are much better. Primary gaze, you can see the lines are so close to each other that the patient has a face turn in left gaze. So what is our aim of our management? Stabilize the eye by improving visual acuity, decrease the eye movements if possible, shift the null to primary position if there is a null. And how do we actually achieve improvement of vision? So this is kind of a nystagmogram flattened out a little. The patient is able to see when the object of regard is within plus minus 5 degree at a speed which is lower than 4 degrees per second. So only for a very short period of time, and that's marked by these red lines, is the patient able to see. All other times, any impulse coming from the retina is actually suppressed, like it is suppressed when we do a saccade. During our saccade, we don't see things moving. The image just remains on the brain for a bit, and then the new image comes on. That's what happens in nystagmus. So it's only in these periods that a patient can see. And how can we bring about a change? When we flatten out these images, so this period above these lines is the time when the patient can see, and that's the time how you are helping the patient to improve. What all can you do? So you have a target, you have the retina, refractive correction, get good quality imaging. The nystagmus can dampen. As it moves higher and higher, you have on the motility, you have drugs in neurosurgery from higher centers to the ocular motility system, and from motility system to the extraocular muscle, there are biofeedback mechanisms including acupuncture, and finally from the extraocular muscles to the target, you can have surgery, botulinum toxin or prisms. A lot of options. Optical correction remains the single most important intervention you can do. So please, first step, do check best corrected visual acuity always. Retinoscopy in null position, you can think of over minus classes, particularly in INS, as accommodation does tend to dampen the intensity of nystagmus and therefore improve vision, but the patient has to be able to do that. It's not always an easy thing to do. Management of amblyopia, again a single most important thing, you must manage it. Occlusion is actually not an absolute contraindication. You see an initial increase in the nystagmus, but as the vision improves, it profoundly influences it far greater. However, if there is an initial difficulty or resistance, you can do penalization or over plus glasses and then go on to occlusion as the visual acuity improves. Prisms can be used to stimulate convergence, which will dampen the nystagmus. You can use prisms to check the amount of head posture and measure the change in the head posture, and we prefer to use Fresnel prisms. Medical management, you have a lot of drugs. Most of them are useful for acquired nystagmus. For congenital, we did this study on brinzolamide eye drops, and we found it to be relatively effective in those patients who do not have a head posture. That of course is under print right now, and there is now a topical medical management that can be considered. Some of them do actually feel better. Botulinum toxin, however, it's a short acting, so again only for acquired. Alternative therapies, contact lenses help not only by contact tactile method dampening the nystagmus, but also the eye moves with the refractive correction and therefore he sees better. Acupuncture is something we tried in our hospital. You can see before needle insertion and with time the flattening occurs, but the moment we remove it after 20-30 minutes of removal, it tends to go back. So during the period, the patients were extremely comfortable and happy with the acupuncture device. You can do surgically. The aim of surgery is either inducing convergence, shifting of the null position, or to reduce the amplitude of nystagmus. For shifting of the null, correction of face turn, you have numerous procedures. We use the augmented Andersons in our hospital and we tend to find it very beneficial. You can dampen the nystagmus either by supramaximal recession of all four recti or the Hertel-Deloso all four recti, horizontal recti tenotomy procedure. Face turn, like I said, we use an augmented Anderson's procedure. We do the recession of the yoke muscles, a very large recession. Again, it can be proportional or dependent upon the amount of head posture, up to 12 mm recession of the lateral recti and 9 mm of the medial rectus. The benefit is that just in case if you operate a pan or it shifts onto the other side, you can do the opposite yoke and get the correction. And the limitation to eye movements is not too much. It is of course easily reversible. So these are some of the cases which we had done. This is again a picture to show you how on electronystagmography there is a change. This is the primary gaze you can see after correction of head posture. This was on dextro and levo version, which remains. However, the null has been now shifted to primary position. It was here in the levo version. Again, you can correct for chin up and chin down positions, for head tilts where you can do oblique muscle surgeries. This child had a head tilt and we operated on bilateral superior and inferior obliques to correct for it. And to decrease the nystagmus amplitude in those who do not have head posture, you can either do all 4 horizontal recti recessions, supramaximal, doing again 12 millimeter lateral recti, 9 millimeter medial recti. The effects is not very long lasting, and therefore it's not something we routinely offer to our patients. The other option was the Hertel-Deloso procedure, in which they just remove the horizontal recti, cauterize the stump and replace it there. They believe that it helps in managing the tactile sensory fibers that are there at the nerve endings. And well, we've tried it in our center, and we did find that it works equally well compared to all 4 recti recession, which is not saying much actually, because even that does not work so well. But an option can be given to either of the surgery in patients who have nystagmus without a head posture. Therefore, like I started off with, these are exciting times. There is a lot of things that are coming, and we hope that over time there will be more opportunity to offer and manage our patients.